flow chart, those who are known hypothyroid on stable dose of levothyroxine and having a documented report in past 3 months, as well as who are suspected for hypothyroidism and detected to have subclinical hypothyroidism, then they can proceed for surgery under usual risk. Regarding moderate hypothyroidism, if elective surgery, it is better to replace with the dose we have already discussed, but ideally proceed with surgery once euthyroid. And if urgent surgery is required, then we should start replacement with levothyroxine dose according to the age and presence of cardiac comorbidities. They can proceed for surgery under moderate risk. But people with severe hypothyroidism are always at a very greater perioperative risk. And for elective surgery, always it is preferable to proceed once they are euthyroid and hemodynamically stable. But if an urgent surgery is required, then we need to replace with intravenous levothyroxine, but however it is not available here, and then 50 microgram daily, and may require to give liothyroid as well. And if we are not aware of, if the hypothalamo-pituitary adrenal axis status is not known, or if the patient is hemodynamically unstable, then we should start glucocorticoid before giving levothyroxine. One important point to note here that patients who require cardiac revascularization are the only subset of patients who may not benefit from pre-operative replacement of thyroid hormone. And for them, it is reasonable to proceed with the revascularization procedure before repleting the thyroid hormone. Having said that, the risk of worsening unstable coronary syndrome with thyroid hormone, that is mostly increasing the myocardial oxygen demand, conflicts with the concern that untreated hypothyroidism may worsen heart failure or hypotension in the cardiac surgery patients. So the next part is hyperthyroidism. If you look at the cardiac risks in hyperthyroid patients, there is high prevalence of atrial fibrillation both in overt as well as subclinical hypothyroidism, and there are factors which can lead to persistence of AF after treatment, like old age, the duration of hyperthyroidism, and duration of pre-treatment atrial fibrillation. Regarding ventricular arrhythmias, the patients with heart failure are at very high risk, and the electrical storm defined as hemodynamically significant VT, if those patients having this underlying etiologies of myocardial ischemia, electrolyte imbalance, and other endocrine disorders, they are at very high risk of these ventricular arrhythmias. Regarding heart failure, the causes we know, there are two types of heart failure. This high cardiac output failure described long back in 1970 that leads to tachycardia-induced cardiomyopathy, and the low cardiac output heart failure, mostly seen in elderly in a lesser percentage, that increased in patients with hyperthyroidism who are suffering from cardiac disorders like ischemic heart disease, hypertensive heart disease, valvular heart disease with or without atrial fibrillation. Other possible complications are angina, malabsorption, dehydration due to hyperthermia, respiratory muscle weakness, hypercarbia due to increased oxygen consumption, hypokalemia, and last but not least, the thyrotoxic crisis. So, regarding the approach to pre-op patients having hyperthyroidism, case of elective surgeries, prior optimization to be preferred. Need to ensure severe safety using the beta blockers in old age, that is, who are aged more than 50 years, or those with cardiovascular disease, especially atrial arrhythmias, and may taper after recovery. In case of emergent surgeries in overt hyperthyroidism, we need to decrease liver thyroid hormone synthesis as well as to block peripheral conversion, and also you block the sympathetic actions. And prevention of systemic decompensation with adequate nutrition and fluids are also important. So sometimes rapid preparation for surgery is required for thyrotoxic patients, and we may not have sufficient time to render them euthyroid by thianamides before surgery, or maybe thianamides may be contraindicated. So this inpatient regime for rapid correction of thyrotoxicosis may be a week before thyroidectomy, may be followed using beta blocker in this dose propranolol 60 mg twice daily, that can be continued post-operatively. Dexamethasone 2 mg intravenous 4 times daily, that should be tapered over first 72 hours. In place of dexamethasone, we may use hydrocortisone 100 mg 8 hourly. Cholestyramine 4 mg orally 4 times, that should be stopped immediately after surgery. And saturated solution of potassium iodide 2 drops orally 3 times may be used, no need for continuing post-operatively. In place of SSPI, levodopa may be used, is having 8 mg of iodide per drop. So if you look at this approach of suspected or diagnosed patients with thyrotoxicosis before surgery, if this is a case of iatrogenic thyrotoxicosis or underlying thyroiditis, or if the condition is considered subclinical hyperthyroidism chemically, then they can proceed with surgery under beta blocker. On the other hand, with overt hyperthyroidism for elective surgery, with use of antithyroid drugs and beta blocker, patient should be rendered euthyroid and hemodynamically stable prior to contemplating surgery. For urgent surgery, it should be in overt hyperthyroidism, they should be managed as a impending thyroid storm with antithyroid drugs, iodine, beta blockers, and steroids. And they should be taken for surgery under very high risk with an arrangement of ICU. So the key takeaways from this presentation: both hypothyroidism and hyperthyroidism increase risk of adverse cardiovascular events during perioperative period. In case the surgery required is elective, optimization of thyroid functions prior to surgery should be preferred. There is, however, no need for delaying surgery in mild to moderate hypothyroidism, because most of the studies have shown that there is no difference in adverse outcomes between untreated moderate hypothyroidism, treated moderate hypothyroidism, and euthyroid individuals. Myxedema, coma, and thyroid storm are potentially fatal complications, and meticulous monitoring in unoptimized cases is indispensable. Patients with overt hyperthyroidism requiring urgent surgery should be treated with multi-modalities including antithyroid drugs, beta blockers, or calcium channel blockers, and should receive intravenous fluid for hemodynamic stability. So thank you for your attention.